In many Western European countries, we have a socialized system where the individual, the patient, never actually pays or never actually has to concern themselves with the cost. But we still need to instill a knowledge about costs in healthcare staff. They need to understand that to everything we do, there is a cost associated. And this is not that they should hold back on any treatment because of cost, but they need to understand it and be able to discuss it.
Hello, everyone, and welcome to the Bedsides and Boardrooms podcast, where we speak about the intersection between business and medicine. Today, we're going to be speaking about medical leadership and healthcare systems, and we have got Dr. Marcus Larsson on the line. Thank you very much, and welcome, Dr. Marcus.
Thank you, Nathan. Thank you. It's a pleasure and a privilege to be on your podcast.
Can you give us an idea of what you've done in your career so far?
Okay, yeah. So I'm from Sweden, and I've trained at the Karolinska Institute in Stockholm for medical school, and after that I became a general surgeon and an emergency physician. And the reason for that duplicity is because when I started, emergency medicine didn't exist in Sweden. So with that in mind, I had to choose another specialty first. So then I became double boarded and have then spent my time in clinical surgery, in emergency surgery, maybe no surprise, and eventually drifted into managerial positions. And before med school, I actually attended the Stockholm School of Economics. So I have a master's in business and economics. And I think that is what pushed me into the managerial parts and those challenges. On top of the clinical. Now I'm here in Abu Dhabi. So, working as chief medical officer in a unit delivering healthcare in unconventional places.
Do you think that you became a manager because of your previous degrees in business?
Yes. Yes, partially. No, completely yes. And the reason was, when I started in medicine, this was very interesting for me, at least. So, especially in Sweden, in a socialized system where there is, we never talk about money in medicine because, as a physician or as a clinician, you never encounter it. It's always it comes something from the boss or something from the politicians or something distant, which creates a very interesting environment. When people are talking about resources and using things and ordering examinations and medication and so on. And for me, with a business background, I just thought that it was so very strange that we never discussed it. And it was kind of the everything for everyone attitude. And I just found it so fascinating that they were not thinking about, that regardless if there is no price tag, there's still a cost. Or alternate costs for different things, or the hidden costs in having to recruit people, for instance, or whatever. So after a while, and after encountering the fact that my bosses early on in my career, they were also not very well versed in this thinking, I became very curious because I thought that many of them were slightly crazy. So I thought, is this because being a boss in socialized medicine, does it make you crazy, or do you have to be crazy to go into leadership? So then when I had I was 1 year in after finishing my specialty, this opportunity turned up to be a manager in a community hospital in the city where I lived for internal medicine, actually. And I applied and I got it. I was 39 years old. So I started working as a manager. That was my first encounter, at least formally. Then that sort of, that was dysfunctional. After a year and a half, approximately, I went back to clinical work, and then I tried to develop things within the clinic. I moved to the far north in Sweden, tried to implement emergency medicine at that county hospital. But then with driving all these small projects, I was eventually recruited down here back in 2016. So I started here in 2017 over in the Emirate of Ajman. And then from then on, it has been a lot of managerial jobs in very many different positions.
Yeah, it's interesting that you speak about the financial side because we're going to get into that a bit later on the episode. But what I my wife has just given birth to our first.
Congratulations.
We are now 2.5 weeks into the journey. So I don't know if you can see underneath my eyes. I've got bags under my eyes because I haven't slept in about 3 weeks. But we went through some birth classes and we had an encounter with the midwife, and it was a really perfect. Um, it explained this financial medicine very well because the midwife said you can get an epidural, but you have to pay a certain amount of money. I don't know how much it was, but you have to pay. So you have to go in and you have to pay. And she said, for me, I don't care. I'm a midwife. I don't care if you pay or not, which I think is really interesting because not very many businesses or organizations run on the fact that the people actually providing the service do not really care if the person pays or not. So I think that was just, and also from my side, I always have this like, as a clinician, we have this like feeling that, I don't know, maybe it's a bit of arrogance or maybe it's a bit of just, we want to do what's ethical, but we feel that we do the best for our patients and money doesn't really matter. But that's not actually true as at an organizational level. So how do we kind of balance the fact that there is these financial constraints on our organizations, but we also have to do the best for our patients?
Quick answer is awareness, right? It's like so with many other things, just education and awareness. The first thing is you have to consider in which context you are. So if we would look at the, like in many Western European countries, we have a socialized system where the individual, the patient never actually pays or never actually has to concern themselves with the cost. But we still need to instill a knowledge about costs in healthcare staff. They need to understand that to everything we do, there is a cost associated. And this is not just, this is not that they should hold back on any treatment because of cost, but they need to understand it and able to discuss it and to, on a larger scale, maybe consider what are we doing? Is this practice, is this best practice? Is this the best justifiably financial best practice? Or are we just wasting resources, i.e. money, right? And I've tried to raise this in Sweden, and people immediately become defensive, and then they say you shouldn't put money on people's health, or put a cost on people's health. And then I try to tell them this is not about the patient. This is not about putting a cost on whether or not somebody should be healthy or not. This is about resource stewardship. But by that time, many have just turned off. But I think for me, that is so super important that everybody needs to understand, I mean, for instance, if I'm the OT, I'm choosing between two different ways of doing surgery and both have the same clinical validity. Why shouldn't I choose the one that is less expensive, Or I could consider, do I need the super duper space needle to suture this skin wound, or can I just take any old cap gun? So it's because resources are going to be more scarce, and it's going with the aging population all over the world. There will be more healthcare consumption. There will be more costs, and we need to be wise about this. And you can do this in many different ways instead of doing radical big changes in society. Then looking at a system like here, where everything is for pay, you also have to be considerate about especially if the patient is self-pay, you should of course give the patient the option to choose and have the patient very involved in the financial decision making. Actually, well, just like we are very cautious or very conscientious about having the patient involved in medical decision making, right? I usually tell the baby doctors that we are the patient's consultants. We are not the patient's dictators. We're not going to tell them what they have to do and they have to follow it 100%. We are there to suggest these are the options, and then we recommend that this is my recommendation, that this is the possible outcome. But then that the patient feels that they are the ones to make the final decision with my support. And the same thing should apply when it comes to cost. that we should be able to provide for the patient, an openness and a transparency in this decision making. That can be very difficult for some patients. Some of them, they don't have the resources or the competency in themselves to make that, and then we should facilitate. Because in the best of all worlds, well, I guess we're going to get into this later about the insurance system. In the best of all worlds, the system is balanced and fair, but there is no utopia. There are always going to be flaws that are going to tilt systems back and forth.
Yeah, I think that's an interesting thing, because unless you work as in procurement or something like that, like I started my career as a clinician, obviously moved on later, did different things. But when I was a clinician in those first couple of years, I would go and open up, crack open a drug, give it to the patient. I would open up an IV line. I would give it to the patient. I had no idea what the actual cost of those items were. I just had a bag and it was fully stocked, and I just administered what I needed to do to the patient. So it never actually, the cost of the procedure that I was doing on the patient never actually came into my decision making, which is in some ways good, but in other ways, as you said, it's awareness. They're not, clinicians aren't aware of the cost of these things. So you've transitioned from, obviously, you started out as a clinician and then you moved into management. So what are some of the challenges that you've experienced going from clinician to management?
Well, I mean, what are some of the? Yeah, I've been thinking about that, and it was not so difficult to change roles. Not for me personally. I felt that going into leadership, leading people, I've done that in other contexts, the scouts, and I've led people across the mountains and through the forests and all that. That to take the responsibility that came natural, but it's been more. Sometimes it's been very difficult to stay connected, to keep the clinical context, because especially in Sweden, where I started out in the managerial field, it was or the county government tried to push the idea that being a boss is it's a job by itself. You're no longer a doctor or a nurse or a physiotherapist or a IKEA manager. You are now a healthcare boss. And so you should sort of let go of your previous connections to your colleagues and stuff. Now you're bossing, and I never really bought into that. I feel strongly that I have two very strong principles. Where one is that when with regards to remaining clinically active, and the first one is that unless you have your fingers in the water, you'll never be able to judge the temperature. So you need to be in the clinical in clinical work and able to, in order to be able to you want to hear the talk around the coffee table. You want to see if I'm doing an endoscopy, why don't I get my little biopsy clips? Why is that not coming? Why didn't the patient show up? Why were they late, or why were they early? And all these small things that never come to the boss. They never come to the head of department. They are sort of filtered out because people don't think it's so important, but it's the devil's in the details. And if you're not clinically active, you lose that touch. And my second principle with regards to this is that you will lose the respect of your colleagues if you are no longer clinically active. And that's how doctors are. We respect people who are clinically active and do the physician's job. If we step away and become a desk jockey, then regardless of what they say, you will have less respect. And having respect as a manager.
From an organizational level, how do you strike a balance between being a manager and a clinician? Just how do you implement that at your organization?
Yeah. So previously, when I have held management positions, for instance, lastly, when I was head of ED back in Sweden, I made sure to have clinical duties. So a day per week, I was out and I was the I worked as any ED consultant, but I had a focus on the surgical side. I led traumas and so on. And before that, when I was head of surgery here in the UAE, I made sure to do the rounds every morning with the team, and I assisted in certain procedures when there was time and opportunity. So I made sure to have the clinical connection. Now, in my latest position here, as I said initially, we are running healthcare or providing healthcare in unconventional locations. So we're talking deep in Africa in field hospitals. We're talking a ship hospital. We're talking clinics in various government authorities here in Abu Dhabi. So, and it's very, very difficult for me to be clinically active. And this is probably my greatest concern regarding my own career right now, is that I cannot really do rounds in the Sahara Desert or out here in the various ministry clinics. So I'm just having to manage as well as possible. But this is for me extremely, extremely important that an organization would provide for this. And an optimal setup in a progressive modern organization, the organization should make sure that managers with clinical backgrounds had the opportunity, or were rather strongly encouraged, or maybe even incentivized, to maintain their clinical practice. And as I said before, partially to be able to be deeply connected to the organization and to the to the general work that's going on, but also to maintain the respect of your colleagues. So I would like to see maybe more of a discussion around this, and not just here, also back in Sweden. Like I said, they want to see being a manager to be like a job by itself, which is a position that I don't agree with. I think that we cannot lose our professional connection. That would be detrimental for the organization and for the patients in the end.
So just from a practical perspective, you said 1 day a week.
Yes.
To maintain your clinical skills and to get an understanding of what's happening in your organization clinically. Would you say that that's the sweet spot, maybe 20% of your time spent clinical, or do you think that you could go a little bit more or a little bit less, maybe once every 2 weeks or twice a week?
I would say that less. I mean, maybe we could talk about half a day per week, but I think there is but to do it less frequently, like once every 2 weeks, half a day is probably optimal, because if it becomes with a greater periods in between, say 2 weeks, then if you miss once, then it's 4 weeks, and all of a sudden it's a lot of time. But that would also depend a bit on the service and what you are providing, what you're doing, how highly specialized it is. If it's super specialized and you're a manager of like a pediatric cardiothoracic unit, there aren't that many procedures, and you might have to sort of more attend at those times when there is something very specialized happening. And then, of course, there is also, I mean, sooner or later you will reach a level where it's impractical. I mean, if you are a group CMO, it might be very difficult to go down into a specific unit to do your job. And there might be so many things that are pulling at you, or if you're a hospital director or something, then it can be very tricky to maintain a clinical presence. And maybe, there are other things to focus on. But I think on the unit CMO or medical director or head of department level, then I think it would definitely be something that the organization should encourage, clinical activities.
And it's so important. I mean, so many managers, hospital managers, even people that are just managing a small team, they don't actually spend any time clinically. They just do all their administrative roles, managing HR, all those kind of things, and they lose touch of that side. So I think, I mean, when I was moving from a clinician to an academic, I pushed to do once a week, and I think that was about the sweet spot. So, I mean, you've worked in really highly developed, specialized systems, healthcare systems in Sweden, and now you are also involved in building healthcare where there's almost no healthcare. Can you tell me, and we laughed a bit about this in the pre-recording episode, pre-recording little chat, but can you tell me what you've learned from working from, uh, the most specialized
Absolutely. So
places where there's no healthcare?
One of the things that I've done also, which we didn't mention initially, or I didn't mention, is that I've been in the Swedish Air Force part-time for about 8 years and full-time for 2 years. And that was what I was doing just before I came here. And there we did a lot of training of medics, paramedics, nurses, unit medics, ranger medics. And they all want to do the advanced stuff. They all wanted to do, surgical procedures and all this, where we had a cool kit and it was dangerous. But we told them, if you want to do advanced stuff, do the basics exceptionally well. And this applies also to healthcare in general, that if you want to build a hospital, if you want to create healthcare in a remote, rural, austere, difficult area, focus on doing the basics exceptionally well. So what I've been in very primitive locations where they're providing what, at least, I mean, for my eyes, while I was there doing the site visit, seemed like solid healthcare. It wasn't fancy. They didn't have all the machines. They did definitely not have a surgical robot. Many don't even have a laparoscopy tower, but they were providing healthcare and they were doing it well because they were doing the basics well. It was clean. It was, maybe the floors were cracked. Maybe the walls didn't have haven't been painted for a couple of years, but they kept it neat and clean and orderly, and they had their procedures in place, and they did basic healthcare very well. Other places I've been to have been very gritty, very dirty. I mean, outright filthy. Things were broken, not fixed, not repaired, not replaced. And just going inside to some of these places, I felt that I was, entering I should be wearing a hazmat suit, and they are requesting stem cell transplant. And, and then I'm thinking, if you cannot even sweep the floor or get somebody with a rag and a bucket and just wipe off the circuit breakers because they're sticky, then you shouldn't be talking stem cell transplants. So doing the basics exceptionally well is a good start to then go on to more advanced things. But you need to know your basics, and then also included in this is actually working with your medical quality. Now, this can sound very boring, and maybe something that you think that, oh, let's do that when everything is up and running, but it's the contrary. Unless you know what you're doing, you can never improve. You can never find the mistakes. You can never find the risks. So having these things going parallel, you build from the bottom up, and you constantly monitor what you're doing, then you will provide good healthcare for your patients. And that does not the latest AI driven healthcare. I mean, what do you call it? Electronic medical records, EMRs.
Yeah, we've had a guest on the podcast before speaking about designing healthcare systems in remote settings, and he spoke about having a clinical floor and a clinical ceiling, and then kind of deciding what part of medicine you want to provide to patients. Is that something that you do when you are starting from scratch and there's nothing there, and you decide what is the minimum, or maybe I want to be able to plug up a wound if there's, so we need to have gauze, but there's, you can't do cardiac surgery, so that is outside of that's beyond the clinical ceiling. Is that something that you start with? And if so, how do you go about doing that?
Usually our basic basic building block is the generic 100-bed hospital. And this hospital will have inpatient, outpatient, OT, laboratory, radiology, and then all the other things, the gas plant and the generators and the medical waste and all these things. Right? And then and this is then on a level where you can provide the basic specialties, internal medicine, general surgery, ortho, peds, and then we build on that, and then, okay, maybe and then we have add-ons. Okay, you want maternity, we'll add that, because that will require labor room, that will require a NICU or at least a SCBU as a special care baby unit, and so on. So, and then like a stepwise construction, not as a physical building, but as a healthcare hospital system. And then, of course, this can be built, up until the tertiary university hospital level. But for our, like in our scope, we have never been that far. Many people are just happy with us setting up a basic hospital. Is that we have this 100-bed unit, and then we will, of course, discuss with the client and see what do they want, what is their scope, and then we will modulate this 100-bed unit to fit the requirements. Some of them want a dialysis center. We've built that, and then, of course, then we won't have any maybe no orthopedic outfit. That's not what they want, but we will make sure to have a vascular surgeon and a nephrologist, and then we are sort of going in that direction. Others have had other requests. Some want and then interventional radiology is something that many want, but then we usually tell them, okay, let's start to build a unit which has like internal medicine and maybe a cardiologist, and then once we have built that and recruited those patients, then we can consider the next step, and actually because so one of my other points that I was actually thinking about before our meeting here today is that management needs to understand medicine, and this also applies for the client. So many places in the world, they want interventional radiology. They want a cath lab, and that's good. That's nice, but you cannot just put a cath lab on the savannah and start popping in stents in people, right? So you always these complex procedures, they need to be in a context. Because you always need to be able to take care of the complications. So therefore you need to build the basics, and then you can add on the advanced stuff.
Yeah. That's such an interesting point, because if you say have a cath lab, if you look at what it takes to create a cath lab, you need a surgeon, you need the equipment, you need a room, those kind of things. But outside of that, you need a way of the patients getting to your cath lab in time. You need post care, you need an ICU, you need nurses. So the actual amount of equipment and personnel you need to just pop in the stent is this part of,
yes,
and all
many
of that
many countries in Africa, they're really keen on getting started on organ transplants, and that's also nice and well, but organ transplant that requires also a whole network of people. Everything from finding donors, spreading information in the population that you can sign up as a donor and donor cards, and then keeping inventories of these, and then doing the screening and the feasibility, and to see if they are a match to the patient and so on. To having the clinic where you can find the patients for kidney transplants or liver transplants or whatever it can be, and then having the units where you can actually perform the surgery. And I mean, a kidney transplant today is maybe not that advanced, but a liver transplant is a huge undertaking with a high mortality risk, both for donor and for patient. So, and then of course, then there's a follow-up, because once you get somebody else's organ, you will have to take medication for the rest of your life. And that is a challenge in some of these countries. I mean, I just had a mortality morbidity conference where we had to realize that a 17-year-old died from diabetes type 1 because there was no insulin. And you know, in today's day and age, that is pretty brutal.
So you're constantly having to balance how much care you provide to patients with the financial or the resources required in order to get that done. And I think that there's an ethical balance in this where you can say you can create a platform or the ability to do an organ transplant, but how much more, it's a bad term, bang for your buck do you get when you offer primary healthcare to, you know, so many more people? So how do you maybe just go about the financial side as well? Is there a certain amount of resources that you try to allocate, or is it just this is the budget that we've got, we're going to put most of it
Yeah,
into
so for our
this
units,
part of healthcare?
so far
How
they
do you
have
go
all been
about that?
humanitarian. We create healthcare solutions for foundations and government departments who want to support developing countries or conflict zones in Africa and the Middle East. So so here, another thing, you know, you have these, you set up these units, and we staff them, of course. But where do we get the staff from? Well, we recruit healthcare staff from more or less developed countries, you know, the Middle East, India, and so on. And they have they come there with a commercial mindset or a insurance-based mindset. And then we have to work with changing their mindset into that this is humanitarian medicine. This means that, you know, you get a budget and you have to spend it. Nobody will give you a gold star for having money left over at the end of the year. Uh, yes, and the client
Actually, it's
says,
unethical
because
in
the
order if
client
you have
giving us
money at the
a
end.
certain amount of money to spend, they want to have the maximum, as you said, bang for the buck. They want to have the maximum healthcare provided for this donation that they have made. And if there's money left over, we haven't filled our commitment. So that's why well, it's interesting. I tell them that, you know, if we're under budget, we're inefficient. And if we have consumables, medications, or other things left over at the end of the year, that is waste. And this can be, I've noticed, this can be quite a challenging concept to get across to the units, because they are in the sort of, you know, let's save our money, let's save our resources, let's reduce our costs, as we would here in the developed world. And that is kind of interesting. And then we have other units here where we have, I mean, in the insurance-based healthcare that is provided, there is an incentive for some colleagues to prescribe like comfort medication, some extra vitamins, or some ointments and this and that, like functional medication. And then that is prescribed in contexts where that is completely inappropriate, because we do want to minimize the use of pharmaceuticals during a certain time period. So yeah, it's interesting to work in. As I said, we work in unconventional environments. We're the Department of Unconventional Healthcare.
That's a real challenge when it comes to actually creating a healthcare system. So many healthcare systems, when you start working in them, it is what it is, and there's not much you can do. But actually creating that healthcare system is always a challenge. So just stepping away from creating one, you say, unit of healthcare, or going into a certain area and creating healthcare, what do you think is the best way to fund healthcare? Just as a healthcare system,
So the whole system,
necessarily just a single project?
I'm highly personal opinion, but I think that healthcare should be funded through tax money. I think that everybody should contribute, and that the government should support or finance healthcare. Mainly because that is the fairest way to make sure that everybody has access. and maybe then I mean there will, in such a system, such in Europe, there are no VIP wards, there's no preferential treatment there. You get treated based on your need, and that for me is the fairest way to provide healthcare, which is also personal opinion, but for me it's a human right to get healthcare. Then, of course, that this is on the painting with a big, broad brush, right? Then, if you get down to the nitty gritty, then you have to decide what you want to provide as free of charge, or what not. So, I mean, there are some things, there's the cosmetic side, the plastic surgery, other augmentations that probably should not be provided by the common by tax money. But definitely emergency care, life-saving care, cancer treatment, biological medication for rheumatological disease, things that are very difficult for an individual to carry financially. And child.
What? Yeah. So, what do you think of co-payments? Do you think a small co-payment is reasonable for almost all healthcare? I'll give an example. In the UAE, whenever I go to the doctor, I pay something like $13-14 in order just to see the doctor. So I don't know if that is a barrier to certain people accessing healthcare, if that's what would be a relatively small amount of money. And then there's some kind of co-pay. I mean, my wife's just given birth and we had to pay a certain amount. Can't remember how much it was. 2,000 dirhams, maybe that's $300-400. But I mean, we got all of the care. We stayed in a hospital for whatever amount of time. So what do you think of, just having a small copay as part of healthcare?
A small copay is reasonable. But I think usually in order for it not to be prohibitive for a significant part of the population, the amount of money that you actually get in compared to the total cost is still going to be, I mean, it's not going to be significant for like a county's or a Emirates collected healthcare cost. But so it's rather going to sort of adjust people's psychology so that you don't go to the doctor for any little ingrown toenail or a pimple or whatever. I actually did a blister once, then I felt that maybe the copay could be a bit higher in the EU.
That's a good point. Dr. Larsson, we have a tradition on the podcast where we ask the guest one question that they haven't seen. So your question today is it ethical for healthcare organizations offering clinical services to make a profit?
Yes, I think so. Once again, it depends on the context a little bit, but so profit is an interesting word. And if I put on the sort of business degree glasses for an organization that is private and that is responsible for its own costs and revenues, you have to have a small profit. Otherwise, you're actually running your business at a loss. But then, of course, everything goes back to the size of the profit, right? How much do you actually? I mean, if you're making tons and tons of dollars or dirhams or whatever, then we glide into the unethical side of it, maybe. But for a private organization to make a profit, I think that otherwise you have to. Otherwise, you will go bankrupt. But the interesting question is, how much do you make? Then, of course, you also have the question of in what context are you operating? Are you one out of 50 hospitals, or are you the only hospital available? Because if you're the only hospital available and you are, have very high prices, then it's, what's the word? Usury? Here my English fails me. But you're actually, you're using the population and you are extortion. It's almost extortion. But exploitation. Thank you. Yes. So it's a
Exploitation.
tricky question, but I
Yeah.
definitely think, a private hospital, if that's the system, if that's the setup, yes, they must be allowed to make a profit. I think that a profit margin of maybe, looking annually of 7 to 10% would be justifiable. And if you go a lot beyond that, then maybe you should increase the salaries for your staff. Or you should consider investing in more services. Maybe you should get that cath lab if you don't have it, or maybe you should look into, children's cancer treatment or other things where you can increase the utility for the population. I strongly believe that we are in healthcare to help people. I don't think that people have gone into healthcare for the wonderful working hours or for the glamorous environment where you work or for the, all the benefits. It's you go into healthcare because you have this desire to help people. So then I think people are happy to see that the money is reinvested into the organization.
I always say that in
Indeed.
healthcare, we get to see the best of humanity and we get to see the worst of humanity. So we get these both sides. Dr. Larsson, thank you very much for coming on the podcast. I appreciate your
Nathan. It was my
time
pleasure.
and it's been great to pick your brain.
Thank you.